then when he stands there, I'll adjust it.
Welcome to everyone for today's Endocrinology Grand Rounds. We are very pleased to have Dr. Dinesh Kalra talk to us on Diabeto-Cardiology, optimal management strategies for the diabetic cardiac patient. It's kind of interesting how the focus in diabetes has moved from microvascular to macrovascular disease. And back when I did my training, and even until early 2000s, we were only concerned about microvascular disease. I think the TZDs were the first drugs that drew attention to this, although they later led to problems. I remember in 2002, they started this journal called Cardiovascular Diabetology, which is now an online journal that is still there. Since the introduction, since their CARD study and doing all these cardiovascular outcome trials for a different reason, we eventually found out things that lead us today to talk more about the impact of diabetes drugs on cardiovascular system, and made us rethink both the physiology and pharmacology of diabetes and glucose metabolism. So Dr. Kalra is currently the chief of the Cardiovascular Medicine Division here at University of Louisville, and he is also director of the Lipid Clinic and the Infiltrative Cardiac Disease Program. He obtained his medical degree from the All India Institute of Medical Sciences in Delhi. Then he did his internal medicine fellowship, internal medicine residency and cardiology fellowship at Baylor. He also did an electrophysiology fellowship at University of Michigan, and advanced cardiac imaging fellowship at Cornell Presbyterian. So I think he likes to keep in training for a long time. He has been a very active clinician and investigator. He has had a number of leadership positions in the American Heart Association, the American Lipid Association, or the National Lipid Association, and has been a great investigator and teacher and won many awards for it. Has been part of multiple clinical trials, and today he will be talking to us on this topic. I invite him to give his talk.
And then invert that and then put it where.
Great. Thank you, Dr. Mokshikandan, for that kind introduction, and welcome everybody. As most of you know, I'm a cardiologist, and my focus is going to be on the newer diabetic drugs and how that intersects and impacts my clinical practice as a cardiologist. No disclosures related to this talk, and Sri already alluded to this, but it's a well-known paradigm in diabetes that you look at complications arising from long-standing diabetes in two big buckets, and one of those is the microvascular impairment that occurs mostly in the form of retinopathy, nephropathy, autonomic neuropathy, and these carry a great deal of morbidity. And then there are the macrovascular complications. And as most of you know, for many decades, we focused primarily on microvascular because we thought that intensive glucose control would certainly help this set of complications, but we were not so lucky with a reduction in things like myocardial infarction or stroke or heart failure, or the progression of atherosclerosis solely with glucose control alone. And it's good that that paradigm is changing now, as I'll show you in some of the data that we've acquired over the last 10 years or so. So cardiovascular disease remains a very important cause of mortality in diabetics. If you look at the major organ systems and how they're affected, there's a fourfold higher incidence of coronary disease and stroke. And for every 1% increase in your glycated hemoglobin, the stroke rate goes up by about a third. Most of you know that diabetics will develop severe peripheral arterial disease. In fact, most of the business that vascular surgeons and peripheral endovascular people see are diabetic patients. And peripheral arterial disease tracks very strongly along with coronary artery disease, and such that when you have people with PAD, about 60 or 70% of them will have clinically manifest coronary disease, but the vast majority of them, over 90%, will have some degree of coronary disease, even though some of them may be asymptomatic. Now, cardiovascular disease, which we'll talk about mostly today, has anywhere from 2 to 6-fold higher mortality, and there's a higher incidence of developing congestive heart failure. Some of that has to do with diastolic heart failure, and we'll talk about that in a little bit. But there's also a well-known phenomenon called diabetic cardiomyopathy, wherein poor control of glucose leads to changes in myocyte function and structure, especially the ultracellular structure, and that leads to problems with diastology and overall myocardial mechanics. Now, this slide is well known to most of you. Early trials that looked at microvascular and macrovascular complications, the vast majority of them did not show a benefit in reducing macrovascular complications, but some of that is now changing. If you look at the long-term data from UKPDS, for the group that was treated intensively with an A1C targeted to 7, they do actually perhaps have, on longer-term follow-up, not in the original set of studies, a slight decrement in cardiovascular mortality and all-cause mortality. That's not been borne out in the longer-term follow-up of other studies such as ADVANCE of EADT, but still, we shouldn't relegate all hope regarding glucose control. I think it still remains a very crucial strategy, if not for microvascular complications, but perhaps also some benefit for things such as myocardial infarction. Now, this data is all, as you may imagine, this data predates the SGLT2s and the GLP1s, which we'll talk about, and that sort of changed this whole theme now that we really want to focus on control of macrovascular complications. In terms of temporal trends, this is an interesting study I found that was published in New England Journal in 2017 that looks at a very large database in Sweden, about 357,000 diabetics, type 2, as well as a smaller number of type 1 diabetics, but still a large number, about 37,000. And shown here is the data just for the type 2 diabetics. As time has evolved and we've gotten better with control of prevention, i.e. statins, blood pressure, glucose, you'll see that there's a decrement in mortality. The red shows you matched controls, and the blue shows you type 2 diabetic patients. So as you would imagine, with the passage of time, and every decade, there's an improvement in mortality, both from all-cause mortality on the left and cardiovascular mortality on the right over the past 50 years or so. But nonetheless, you'll see that the diabetics still have a higher mortality compared to the mortality in matched control. So even though we've made some strides and some progress, there's still work to be done. Now, most people who I see, even though they may be euglycemic at presentation, at some point down the road, they will develop insulin resistance and metabolic syndrome and or frank diabetes. And this is not a surprise. When we enroll people in our cardiovascular trials, about 1/3 to 40% of people will have frank diabetes, but the others are lurking pre-diabetics. And so if you look at these large trials that have tracked the progression of impaired glucose tolerance versus normal glycemia versus frank diabetes, you'll see only a small percentage of our cardiac patients actually are normal glycemic. So most of the times we're dealing with people who have frank insulin resistance or overt diabetes. And as a consequence of that, you have the confluence of cardiovascular disease, diabetes, and the microvascular complications, namely chronic kidney disease. And all of these feed off and amplify each other's detrimental effects. So any acute or chronic cardiac condition impairs the kidney function. right? And vice versa. All of you have dealt with patients who have cardiorenal syndrome, wherein you have renal dysfunction as a cause of cardiac dysfunction, and the opposite is also true. We'd actually published an editorial on this a few years ago when we had looked at patients with transplantation and how the mere presence of any cardiac pathology would alter the survival of patients who were getting kidney transplants. So there's a great intersection between these three systems, and that's why the data I'm going to show you on SGLT2s is really wonderful, because you're not only killing two birds with one stone, you're killing three birds with one stone. You're impacting all of these three different organ systems that are seemingly disconnected, but they all really track with each other, such that a pathology in one of these organ systems leads to increased complications in the other two also. Now, we've known this for a long time, that coronary artery disease and diabetes is a different animal compared to somebody who's non-diabetic who develops CAD. And there's many reasons for that. Listed as some of these, there's a hypercoagulable state, there's chronic inflammation, you get more neointimal hyperplasia, we see a lot more restenosis, and that was especially true in the prior days when we were doing plain balloon angioplasties or bare metal stents. You have very, very aggressive atherosclerosis that starts typically 15 to 20 years earlier than it starts in people who are non-diabetic. And then the clinical outcomes in every possible measure are much worse. And so here I'm going to show you an angiogram and the fallacy of viewing an angiogram in a diabetic and calling it normal. On the left, I would submit to you that most of my interventional cardiology colleagues would say, normal cap, don't come back and see me, bye-bye, you don't have coronary disease. And nothing could be further than the truth. The same patient has tremendous amount of plaque. And the reason you miss coronary disease on a luminogram, which is the invasive angiogram, is because you're not able to see the wall of the artery. You're only seeing the lumen when you inject iodine contrast. And so if you have technology that shows you both the lumen and the wall, the artery models outside by a phenomenon called Glagol expansion to keep the lumen intact. And so as it expands outwardly, you don't see a frank stenosis, but if you are able to see the wall of the artery, it accommodates a tremendous amount of plaque. So that's become a great way of assessing atherosclerosis. And one of the areas of research I'm involved in is looking at this plaque volume and studying it over time to see if therapies are going to change the amount of plaque you have in the coronary tree. Whereas if you just look at an invasive angiogram, you wouldn't be able to tell that this patient has plaque. You would have to employ additional modalities such as IVUS, intravascular ultrasound, or optical coherence tomography to be able to detect that. Now, we talked earlier about how diabetes is also a prothrombotic state, and one of the things that leads to myocardial infarction, as you know, is plaque rupture followed by platelet aggregation and thrombosis. So all of these mechanisms in a diabetic, the increased fibrinogen level, increased von Willebrand fracture, other prothrombotic materials, as well as endothelial dysfunction with adhesion molecules and oxidative stress and impaired vasodilatation, all of these join together to lead to increased thrombosis in our patients. So diabetics have, with the same degree of plaque, a higher rate of thrombosis and myocardial infarction compared to a non-diabetic. Now, given all of that very depressing data, you would think that we tend to treat diabetics very aggressively. Well, you would hope so, because the guidelines clearly tell us to, but cardiovascular drugs are grossly underutilized in diabetes. And some of that has to do with patient reluctance, because these people are on several therapies as it is for both their diabetes and hypertension. Many of these people are obese. But nonetheless, the utilization of cardiovascular drugs is far from optimal. You'll see that the lipid-lowering agents, the high-intensity lipids, statins especially, which should approximate 80 or 90% in these people, have less than a 50% rate of utilization. And I would be remiss if I didn't point out that one of the things we need in diabetes, and the genesis of diabetes, is the problem is you have a calorie-dense lifestyle, nutrient intake, and not enough exercise with modernization. And so the key thing that can help people from not becoming pre-diabetic or changing over to diabetes is exercise, and unfortunately, we don't see enough of that, nor do we have time to counsel our patients. And once you cross that threshold of having a BMI of over 35 or 40, then it becomes really hard to lose weight just by exercise alone. Now here's a table that I found very useful. I think it's for those of you who are here, I'll share my PDF so you don't need to take notes on these. That, for all the drugs we have in terms of what do they do for heart failure, what do they do for the weight, and keep that in mind because I have a slide later that talks about weight and heart failure, which is a very interesting connection, and whether or not they're safe in terms of causing hypoglycemia. And you'll notice at the bottom two, the green, GLPs and SGLT2s, they both cause some weight loss, and they also have a very low risk of having hypoglycemia. And so there's some thought that aside from everything else that they do with regard to endothelial function and the changes on various other things that we'll talk about, that the weight reduction may be an important part of what they do. So the key physiological effects of the newer agents that I'm going to talk about today are reflected here. I'm not going to talk to you too much about the mechanism of action because you're well aware of this, but very briefly, SGLT2 blockers increase urinary glucose secretion. The GLP agonists increase insulin and decrease glucagon, and also have an effect on appetite suppressant, both on the brain as well as by reducing gastric emptying. And the DPP inhibitors increase the amount of GLP that's intact to increase insulin levels. Now, talking about the SGLT2 inhibitors first, they mainly cause glucosuria, so that the transporter itself is responsible in a normal person to reabsorb more than 90% of the glucose that's filtered. And as a consequence of this glycosuria, you get water loss as well as glucose loss. And that's thought to be one of the major ways in which this affects not just diabetes control, but cardiovascular control. So if you look at the cardiac effects of these drugs, they reduce the afterload as well as the preload. They're anti-inflammatory. In animal models, they've actually been shown to retard cardiac fibrosis, which leads to stiffness and heart failure. And they improve cardiac energy efficiency. And on the kidneys, and I'll show you data in terms of benefits on kidney function too, they cause natriuresis. They obviously cause glycosuria, but they reduce glomerular filtration pressure. And so that's thought to retard the loss of nephrons in kidney function, and they reduce albuminuria. So there's a whole host of interrelated cardiac and renal effects that leads to their benefit on these organ systems. And the clinical trials have shown that. So again, this table goes into further detail about how they positively impact heart failure, what mechanisms impact that, and what mechanisms impact the anti-atherosclerosis effect, and what mechanisms have the positive influence on diabetic kidney disease and its progression. And one of the first trials that came out that really made us sit back and think about these drugs not just being solely endocrine drugs, but cardiac drugs was this trial called the EMPA-REG trial, which looked at the control of diabetes in patients who had cardiovascular disease. So this was a large trial published in New England in 2015 with 7,000 patients. The mean A1C of these patients was 8%, and the vast majority of them had cardiovascular disease in the sense that more than 3/4 had coronary artery disease. Some of the others had stroke or peripheral arterial disease. And if you look on the left, the primary endpoint, cardiovascular death, was reduced, as was heart failure hospitalization. Now, both of these were somewhat surprising. As Dr. Mokshagundam alluded to earlier, the FDA would not let you study a diabetic agent without proving its cardiovascular safety, and that came about in the days of drugs such as pioglitazone, where there was a signal for perhaps increase in heart failure. And so all of these drugs were mandated to prove cardiovascular safety, but this was somewhat of a surprise that you had a benefit, not just safety signal, but you had an actual benefit in cardiovascular death. as well as heart failure hospitalization, you'll see that the magnitude of benefit here is fairly profound. You have a 32% reduction in the first endpoint and almost a 35% reduction in the second endpoint, such that the number needed to treat is about 40. Now, one of the things that we know well in diabetes, and I talked about this earlier with diabetic cardiomyopathy and HFpEF, or impaired diastology, is that heart failure is one of the earliest manifestations. So many people that you see in clinic that don't have overt cardiovascular disease will have subclinical atherosclerosis. So if you do coronary CTAs on these people, you will find coronary plaque. But a lot of them will actually have overt heart failure. So if they are actually able to walk, many of these people will be in NYHA class 2 or 3. So they limit the exercise tolerance to such that they may not offer that to you as a symptom, but if you were to put them on treadmills, you will find that many of them do have diminished exercise capacity. And if you were to do invasive tests on these people, you'll see that their left ventricular end diastolic pressure is up and they develop pulmonary hypertension rather quickly. So it was really a blessing that the SGLT2s reduced heart failure in diabetics because this was a huge unmet need. Now, the prior trial I showed you that people benefited from EMPA when they had cardiovascular disease. Now, this trial with DAPA showed that irrespective of the presence of cardiovascular disease, you had a reduction in heart failure hospitalization. So that was really a key moment in us thinking, well, this is amazing because you have people who have subclinical cardiovascular disease and don't have actual heart failure or MI at this stage, but nonetheless the SGLT2 inhibitors are able to prevent this from developing down the road. And again, the hazard ratio here is 0.73, showing a dramatic benefit in the development of heart failure. The next trial that showed us an improvement in this field was DAPA heart failure. This is people with reduced ejection fraction, but not diabetic, okay? So now we have taken the concept a step forward. The first trial looked at diabetes with cardiovascular disease. The second trial looked at diabetes without cardiovascular disease. Now we have removed diabetes from the equation. We're just looking at people with HFrEF. So dapagliflozin in patients who have reduced ejection fraction but don't have diabetes. So DAPA heart failure was, again, a large trial, about 5,000 patients, looking at patients who have HFrEF and who have had at least one hospitalization in the past year, and they're randomized to dapagliflozin versus standard of care. And there was a decrement in hospitalizations for heart failure plus cardiovascular death in this group. So now what you've done is you've retooled a drug that was previously discovered and used only for diabetes, and you're applying it solely in the space for heart failure reduction. And you had a 26% reduction in heart failure. Now that's very dramatic because if you look at the conventional drugs we use for heart failure, such as carvedilol or ACE inhibitors, they have an equal amount of reduction. So this turned out to be a cardiology drug as well as a diabetes drug. And that was a big eye-opener, and that's why this field has really taken off. Now, not only did it decrease the primary endpoint, if you subdivide it into worsening heart failure events and cardiovascular death, those were also favorably impacted. This is another drug. Again, the previous drug was DAPA. Now this is looking at the same issue with EMPA. Similar results, you had a hazard ratio of 0.75 here also. So confirming that this may be actually a class effect rather than limited only to one particular agent. If you look at the combined totality of trials that have been done in this space up until then, it led to a class, this is the European guidelines, but it led to a class 1 indication for treatment of heart failure to reduce heart failure hospitalizations as well as cardiovascular death with a level of evidence of A, because now you have 3 randomized trials at least supporting use in that. Now we move on from HFrEF, which is reduced ejection fraction, to HFpEF. Remember that most of the patients we see in the clinic these days are going to have HFpEF. So about 70% of patients that you see in the office who have heart failure symptoms, i.e. shortness of breath, are going to have a normal ejection fraction. And all of you remember those days, maybe about 20 years ago, when you would look at an echo, you would order an echo for heart failure, and the echo would come back saying EF 55%. You're going to say, okay, you don't have heart failure. We know that's not true at all now, because you could have reserved ejection fraction and you can still have heart failure. And how does that happen? It happens because of altered diastology. So you have abnormal filling dynamics of the left ventricle because the left ventricle is stiff. And so you have increased blood pressure in the left atrium. And that pulmonary hypertension then spills over to the lungs where it causes pulmonary edema. And especially when you walk or exercise, you get more pulmonary congestion. So it's very common for diabetics to have a form of restrictive cardiomyopathy where your stiff ventricle leads to pulmonary edema. So now the paradigm has shifted with this drug that they wanted to test it not just in cardiovascular disease or HFrEF, but you've now moved on to testing it in heart failure with preserved ejection fraction. So this study was designed to have 6,000 patients, all had an EF of more than 40. So, the definition today of HFpEF is more than 50, but for this trial, they had more than 40. They were randomized to EMPA 10 once a day versus standard of care. Remember, standard of care for HFpEF today, there isn't any drug before this class of agents. There was not a drug that had an FDA-approved indication for HFpEF. We were using spironolactone because of some data, sub-analysis from the TopCat trial that showed that it reduced myocardial fibrosis and may help patients, but the overall trial was negative. But there was a signal in North America that maybe there was a benefit, so we were using that. So as of this trial's design, there was 0 drugs available that would help people with HFpEF. So all we would do is decongest them with Lasix and treat their blood pressure. Now, the primary endpoint of this trial was, again, a combined endpoint of cardiovascular death or heart failure hospitalization, and empagliflozin delivered again with a dramatic reduction in heart failure in patients with HFpEF. And surprisingly, the benefit started really early on, right? Within 2 or 3 weeks of administering the drug, showing that there was something about the biological properties of these drugs that were clearly unrelated to their glucose-lowering properties, perhaps more related to natriuresis, their effect on kidney function, their effect on myocyte function, both the energy efficiency in the heart, as well as the reduction of preload and afterload, etc. Now, some of the effect of these drugs is from volume loss, because once you start these agents, all of you are well aware that patients do get slightly dehydrated, their blood pressures may fall, their weight goes down over time. But really, it was a dramatic discovery that we now had a drug that actually worked in HFpEF and was shown in a randomized control trial, and the number needed to treat was very small. You only needed to treat 30 patients to prevent 1 hospitalization for heart failure or 1 cardiovascular death. And that paradigm kept on extending to other agents too. So this is another drug which is not commercially available at this time called sotagliflozin, which showed that for patients who had recently been admitted for worsening heart failure, you saw the same benefit. And this is a common theme in drug discovery and development, right? You test a drug first where you think it's going to work, and then you keep on extending the boundaries, and you tested it for HFpEF later. Now you're testing it for patients with acute heart failure. And so you're continuing to see that benefit no matter where in the sphere of heart failure patients you test this in. Remember earlier I talked about drugs that achieve weight gain versus weight loss in diabetes and their benefit on heart failure? It turns out this is an analysis done that for drugs that are able to actually cause a decrement in weight, you have a benefit for heart failure. So if you look in the quadrant on the left at the bottom, patients who had weight loss, right? So since you lost 2 kilos or 6 kilos, with any agent that's used for diabetes, had a lower incidence of developing heart failure. And the ones who actually had worse heart failure were the ones who gained weight on any agent. So for example, with insulin, you will gain weight. You may control the patient's A1C, but it leads to a higher incidence of heart failure. And so that became a very interesting paradigm. This does not imply causality, but it does raise the question that drugs that obviously lead to natriuresis or long-term weight loss are going to be beneficial in the treatment of our patients. This is from the guidelines. So the pillars of heart failure with reduced ejection fraction therapy have been ACE inhibitors or RAS inhibitors, right? Drugs such as Entresto, ARNIs, beta blockers, mineralocorticoid receptor antagonists such as spironolactone, and now SGLT2 inhibitors because of the data I showed you with reduced ejection fraction. And then, of course, loop diuretics are good for symptomatic improvement, but they don't improve mortality. Now, for HFpEF, we've been using the same agents. None of those decrease mortality, but now for the first time, we have data that the SGLT2s actually do decrease cardiovascular mortality. So the next set of guidelines is likely going to incorporate these drugs as the drugs with the highest level of evidence in terms of preventing cardiovascular outcomes in our patients with HFpEF. Now, we talked a lot about heart failure, cardiovascular disease, cardiovascular death, myocardial infarction, to a little bit. What about kidney disease? So, we talked earlier about how SGLT2s also have renal protective effects. Shown here are the cardiorenal benefits of dapagliflozin in patients with chronic kidney disease. If you look at the key endpoints at the bottom, you'll see that these drugs reduce the rate of decline in GFR. We talked about how they reduce albuminuria, they reduce glomerular pressure, and so that leads to a slowing of their progression of CKD. And that's really important because, again, not only are they affecting the heart, they're also affecting the kidney in good ways so that that confluence of the heart affecting the kidney adversely and vice versa is also able to be ameliorated with this class of drugs. There's an example of another drug, canagliflozin and Credence, showing that your primary outcome of end-stage renal disease or doubling of serum creatinine or renal death or cardiovascular death was reduced with this particular SGLT2 inhibitor. So now the guidelines also list these drugs as a way to not just prevent cardiac problems, but also renal complications in patients who are diabetic. And that same paradigm is now being extended to people who are non-diabetic also. So stay tuned for that. Those trials have started, they're ongoing, but you will see a lot more data on that. This is, again, similar data with sotagliflozin, again, showing a decrement in patients with diabetes and CKD in terms of hospitalization for heart failure, as well as the development of CKD. This is a meta-analysis, again, showing you all the kidney outcomes with these trials. You'll see that the analysis shows you that the forest plot shows you that the combined effect falls to the left of the side of unity, showing there's a benefit of these drugs in chronic kidney disease. And if you divide that based on what kind of population you're studying, whether you're looking at patients with heart failure, you're looking at patients without heart failure but just with CKD, or you're looking at patients with high cardiovascular risk, these drugs, the SGLT2 betters, are drugs that are better for all of these kinds of populations. And as I mentioned, now there's data coming out that they're good for people with CKD without diabetes and without chronic kidney disease. So really, these drugs have become cardiac drugs, renal drugs, and diabetic drugs. And you could have any of these three in combination and permutation, they benefit individuals. Here's another great meta-analysis that was published in JACC 2 years ago, showing the point estimates for reduction in MACE, in heart failure, in composite renal endpoint, and things that really matter, all-cause mortality. If a drug can reduce all-cause mortality, you know this is really doing a good job. A few practical considerations. Most of you have used these extensively. Obviously, we know about the risk of genital infections. Hypoglycemia is a very small risk. We clearly don't use them in type 1 diabetics because of the risk of DKA. When I start these drugs and somebody is on Lasix for heart failure, I will preemptively cut down the dose of Lasix so they don't get, pre-renal and they don't get volume depleted. Initially, there was a signal for amputations with canagliflozin. In post-marketing experience, that's not been borne out to be true, but still the preferred agents are therefore either EMPA or DAPA because of their wide data really in a wide variety of patients in heart disease as well as kidney disease. Now we're going to switch gears and talk a little bit about the GLPs. So again, these have pleiotropic effects on various organs and have many of the same effects we saw with the SGLT2s, namely natriuresis, a decrease in blood pressure, benefits on the coagulation cascade, reduction in inflammation, etc. And they also cause decreased appetite and gastric emptying. So they cause more weight loss. And one of the things that distinguishes the GLPs from the SGLT2s is that the GLPs have more of an anti-atherosclerotic effect and less of a heart failure protective effect. Both drugs, both classes of drugs have both, but in terms of what's stronger, the GLPs affect more anti-atherosclerosis, whereas the SGLT2 effects are mostly on heart failure. So, and you'll see that when it comes to therapeutic considerations as to which drug to choose for any individual, right? So again, these have receptors in cardiomyocytes as well as coronary endothelial cells. That's how they may protect the heart. And in terms of protecting the kidneys, they lead to increased diuresis and natriuresis, they lower the blood pressure, and they cause weight loss. So the first outcome trial in this space was using liraglutide, the LEADER trial, and that showed a 13% reduction in mortality in patients who were diabetic when you looked at cardiovascular outcomes. Again, all of these are going to be at least 3-point MACE, which is cardiovascular death, myocardial infarction, plus stroke, and a lot of these trials will have a heart failure sub-analysis also in there. Semaglutide was studied then in the SUSTAIN trial. Again, this is leading to a reduction in the same 3-point MACE endpoint, as well as a reduction in heart failure hospitalization numerically, but you see it did not meet the p-value for this trial. So there's a lot of basic science work going on to discover why the GLPs may be beneficial for anti-atherosclerosis. And this is a mouse study that you may find interesting, where it downregulates the genes that lead to proatherogenesis as well as inflammation and endothelial injury. And so there is good biological basis for why these drugs may reduce a myocardial infarction in patients. And so we've started incorporating these routinely into our cardiovascular patients, especially folks who have had manifest ASCVD events such as a stroke or a heart attack, etc. The safety is tremendous. You know, they don't lead to hypoglycemia, and there's no increase in the risk of pancreatitis or pancreatic cancer. Here's another meta-analysis of cardiovascular outcome trials showing you that in circled here in purple is the primary endpoint for MACE. You get about a 20% reduction across all of these trials. You'll notice at the very last, the hospitalization for heart failure, it crosses the point of unity, right? So these drugs are not as much heart failure preventing drugs as they are MI preventing drugs. So their effects are mostly on atherothrombotic events, whereas the SGLTs do shine for heart failure events. And again, the renal events here, perhaps about a 10 to 15% decrement in progression of chronic kidney disease. So one final slide to summarize all this data. You'll see that metformin does not really have much of a benefit in all of these, potentially some benefit in cardiovascular death or MACE, but really the bars in blue, the arrows in blue show you where you have predominant effects. So GLP-1s for MACE, which is adverse cardiac events, we typically refer to cardiovascular death, heart attack, and stroke, and the SGLT2s for heart failure and cardiovascular death and renal failure also. Now, I'm going to talk a little bit about other issues in diabetic cardiac patient care. We know that, this is data from going back to about 30 years ago, where somebody who had a heart attack had the same risk of a second heart attack as somebody who was diabetic and had never had a heart attack. That data has been well known, and so that's summarized again here after about 30 years of further data collections showing that diabetes itself is a coronary artery disease equivalent, right? So that's why you see many of the guidelines treating diabetes as a secondary prevention state rather than a primary prevention state. We're very, very aggressive. So the benefit of statins, this slide will illustrate for you. On the left, you see all these trials with the number of patients in them and the statin used, and you'll see the coronary heart disease decrement for the overall population, and in red, the population in that trial that was represented by the diabetic patient. So if you say, for example, you take a look at the 4S trial with simvastatin, which was simvastatin given in patients who had just had a myocardial infarction, the overall coronary heart disease death reduction was 32%, but in the diabetic population it was 55%. And that's not a surprise for us because the higher your baseline risk, right, the more your absolute and your relative risk reduction is going to be. So that's a well-known dictum in secondary prevention that we tailor the aggressiveness of the therapy to the degree of baseline risk that you have. And so I often hear when I give lectures on statins, well, there's a slight increase in the incidence of diabetes over the long run. But they forget that the risk-benefit ratio still overwhelmingly favors statin use because of the decrement in cardiovascular mortality. So, and that point is reflected in this slide, which shows you the degrees of risk people can have when they have diabetes. So somebody who is young and has had diabetes for a short duration would be classified as a moderate risk patient, provided they don't have additional risk factors such as smoking, hypertension, etc. And there, the goal for LDL reduction would be less than 100. On the other hand, somebody who has diabetes and cardiovascular disease, or diabetes that is long-standing, such as more than 20 years, or with chronic kidney disease, any end organ dysfunction, there your goal should be less than 55. And if that individual goes on to have a myocardial infarction, then their goal should be less than 40. Now, these are European guidelines. These are not American guidelines. The Americans really don't have guidelines for goals per se. They got rid of goals in the last lipid guidelines, which was a point of great contention for a lot of people. They basically said you need to drive the lipids LDL low by more than 50%, and if you are still over 70, then you can add on another drug. So they didn't set a goal, but they set a threshold above which you should add on another drug. The Europeans, I think, do it better because patients like to know what their goal is. So do physicians, have I achieved what I want to achieve or not? And then, yes, you can add another agent. So, and these goals are far more aggressive than our American goals. American goals basically say less than 70, and then they kind of refer to less than 55 for very high-risk patients. But the Europeans are much more clear, and I think this is a scheme a lot of us follow. Now, this chart, I'm not going to spend a lot of time because this is from your society and journals. So the point I want to make here is in terms of treatment, the way you choose a drug, if somebody has pre-existing atherosclerotic cardiovascular disease or stroke, then you want to choose a GLP with a proven benefit, something like semaglutide or liraglutide, etc. And if the patient's predominant symptomatology is heart failure, or you're worried about the progression of chronic kidney disease, then you want to choose an SGLT2 inhibitor, provided their GFR will allow you to do so. So I think that's just, if you take away one thing from today's talk, is the utilization of these agents is predicated upon what you're trying to prevent in the long run. Here are some examples of either class of agents. I'm not going to spend too much time on that. I do want to spend a couple of minutes talking about coronary revascularization, and then I'll open the floor to questions. Now, this is an important trial. Coronary revascularization in cardiology has been very, very contentious, and that's because all the data we have so far for non-diabetic patients suggests that coronary stenting or revascularization does not really improve outcomes in terms of mortality. All it does is improve symptoms. So if somebody has angina and then you put in a stent, you're improving angina, but you're not really decreasing myocardial infarction or death. And interventionalists never love hearing that because they want to feel like they're heroes, and that's what they tell their patients, that we saved your life. It's not true outside of few exceptions. And those exceptions are if you have tremendous left main disease, or you have tremendous three-vessel disease, including your proximal LAD and a depressed ejection fraction. So yes, that subcategory of patients, if you take them out, you need to revascularize those people. But for the majority of patients we see who are getting mid-LAD and mid-RCA stents, you're not doing a thing. So this trial, called the FREEDOM trial, looked at multi-vessel disease in diabetics. So this trial was designed for diabetic patients, looking to see what is the optimal revascularization or management strategy for patients with diabetes. All of these people were going to have some sort of revascularization. So their physician had determined they had significant ischemia or they had symptoms, and the randomization was to, you get a stent with current generation drug-eluting stents. At that time it was a Taxa stent, versus you get bypass surgery. And all of these people had multi-vessel disease. This was published in New England Journal about 10 years ago. And surprisingly, CABG came out favorably. So CABG still had a mortality benefit as opposed to stenting in this group of patients. And that data has been borne out by the 10-year follow-up of the FREEDOM trial. And so it's in the guidelines that if you have a diabetic with triple vessel disease, the optimal therapy for that patient, provided they have targets for bypass, still remains coronary bypass surgery. And the reason for that is thought to be twofold. A, you're able to achieve better revascularization, more complete revascularization with grafts. Number two, the internal thoracic artery graft, the arterial graft that the surgeon puts in, confers long-term mortality benefit. Number three, which is perhaps the most important, once you bypass the vessel, the proximal portion of that vessel can continue to have atherothrombotic events without jeopardizing the myocardium distal thread. So, you can continue to have issues in the proximal diseased artery, but as long as you have a graft and distal circulation, that proximal vessel doesn't impact the distal myocardium because you're protected. And that's something you don't get with stenting. A couple of words about antiplatelet agents. So this is data looking at ticagrelor, which is a stronger antiplatelet. So you have aspirin, you have Plavix, and this is Brilinta, ticagrelor. And ticagrelor reduced cardiovascular events in diabetics more than aspirin. And it did so in non-diabetics also, but you'll see the two lines up top, you had a greater decrement of myocardial infarction in diabetic patients who got ticagrelor as opposed to aspirin. But in this case, there was nothing like a free lunch. So it's a more powerful antiplatelet agent. You also get more bleeding. This is patients with diabetes and prior myocardial infarction. Now, if you take patients without prior myocardial infarction, but with diabetes, so this is patients, we see every day in our clinic, diabetic with coronary disease, but no MI yet. Again, ticagrelor was better even in these patients compared to aspirin, but same scenario, you had more bleeding. So the guidelines do not recommend ticagrelor in general for patients with coronary disease with or without MI in diabetes because the net benefit is not in favor of ticagrelor. Yes, you get less atherothrombotic events, but you'll get more bleeding, and bleeding isn't benign. But occasionally we'll have patients who've had multiple myocardial infarctions and are at low risk for bleeding, for example, a younger patient. In that particular kind of individual, it may be reasonable to switch them over to ticagrelor rather than aspirin. So just a summary slide showing you, way we tailor our therapy depends on the patient's risk. If they're moderate risk, then you have metformin. And if they're higher the risk, the more likely you are to choose a drug that's been shown to have benefit, either an SGLT2 or a GLP, and then use high-intensity statin. You can add on a PCSK9 and either use low-dose rivaroxaban or ticagrelor in those patients. I think I'll stop there. And there's your event code. Kelly told me to put that on. Okay. Thank you. Yeah.
That was a great.
Thank you.
Two questions.
Yeah.
One is outside the. One of the questions is what is
Right.
the Indian time? treatment.
Thank you, Dr. Kalra. Is there a chance where, like, would it be, I guess, more beneficial to combine, like, the SGLT plus the GLP-1 plus, like, high-intensity statins? Or, I mean, I would just keep thinking that maybe there would be more added benefits, too.
Right. Yeah, both excellent questions. So I'll take the first one first, the $64 million question about screening. So intuitively, it makes sense to screen people with things such as a coronary CTA. And there have been trials. There was a trial from Utah. The first author was Mullenstein, who screened people within the system they have there. I believe it's called, blanking on the name of the system, the healthcare system. But they screened about 1,000 patients with coronary CTA, were not able to show an improvement in outcomes. So the current guidelines on screening still recommend that you use the pooled cohort equation. You treat people with diabetic with a moderate intensity statin or a high intensity statin, depending on their risk along that continuum. And if you have a patient who sort of does not want to take a statin, or you feel the risk is higher than what the pooled cohort equation is giving you, calcium scoring to risk refine that patient's prescription. Most of these people should be on a statin. However, there is data from MESA showing that even with diabetes, if your calcium score is 0, you actually do have a better prognosis than the pooled cohort equation would tell you. So I do use calcium scoring even in diabetics where they feel like, I don't want to take a statin. Okay, well, if your calcium score is 0, I can hold off another 5 years. So the question on screening is, screening along these lines is okay. I still feel like the reason we have not been able to show a benefit of more aggressive screening, such as with coronary CTA, which picks up non-calcified plaque, which is what you really want to pick up, right? Because you want to pick up somebody who's 35, does not have calcified plaque yet, but is destined to get cardiovascular disease later. The reason the prior trials have been negative is because we didn't have any therapy that would impact the risk of having an MI substantially down the road. We only had statins. But if we're actually designing this trial now, what if you could throw the kitchen sink at them? What if you could give them a statin plus a GLP plus colchicine plus rivaroxaban plus Vascepa, all of that? I feel that you will make a difference. So the degree of therapy you give these people needs to be more than just a small therapy that won't be able to show you a statistical difference at 1 or 2 years. So I still use screening in the sense that if my gestalt tells me this is a high-risk individual, I'll convince them to get a coronary CTA to quantify their plaque burden. You don't need it for everybody, but if you have a particular patient that you're worried about, you can do that.
Diabetes.
Correct.
Coronary artery.
Yeah, so again, I think with technology, everything changes with time and our reasoning changes with time. So 10 years ago, coronary CTA used to give about 15 millisieverts of radiation. Now it gives 0.5 millisieverts of radiation, which is the same as a mammogram. So if you could do a test that gives you a lot more information for the same radiation dose as a mammogram, why would you not do the test unless doing the test didn't impact outcomes? And that's true for a lot of disease states we see. We always say, well, the PSA, if I can't impact the outcome, why would I do it? But then as the treatment modalities improve, you get to a point where you're able to actually change the outcome, provided somebody's done a good enough trial to show that, and that trial's not been done yet. So you're right. What I'm telling you is not yet in the guidelines, and the reason it's not in the guidelines is because nobody's done an adequately powered trial for that yet. The second question is males and females. Again, that goes back to the original concept of baseline risk. And so, yes, the risk is higher in males, and so the benefit is higher, but there is no sex difference in the sense that women also benefit. In fact, for women, especially older women, the predominant cardiovascular manifestations are often heart failure. And so there is no gender discrimination in terms of benefit for heart failure with SGLT2s in women. And certainly for MI also, the GLP-1s work in women. It's just that their risk is lower, so the benefit you see is somewhat lower.
My understanding is rewind is the only primary prevention of artery disease that events.
Mm-hmm.
So, but we still use more semaglutide.
Yeah, I think it's just, some of it is just what you can get covered. And now, obviously, you have semaglutide in oral form, once a week form, so it's just familiarity with the drug, etc.
Weight loss.
Yeah, right.
So what was the relationship between weight?
So if you had more than 2 kilograms of weight loss, about 60% of those people would have a benefit. So you need a substantial amount. Substantial is 2 kilograms is not a lot, but in the diabetic space, it was substantial because before that, metformin would just result in a very tiny amount of weight loss, and insulin would do nothing, just the opposite. So
there's still a role for
ECD?
TZD.
TZD. Well, TZDs, I think they're neutral. So, Rossi got a bad deal after Steve Nissen went after it. And there's maybe some increase in heart failure, but pioglitazone is fairly neutral. I think there is a role, but once you have these agents, how many agents can you add on? Now, people are talking about.
There are a lot of people who are very thin.
Yeah.
For whom, often they have some stomach upset or something.
Correct.
These things,
yeah.
And then if they don't have heart failure
Correct.
or something,
yeah,
then
that would be a good place to use it.
Usually, you're concerned about hypotension.
Correct.
Dr. Kalra, there are some questions in the chat box.
Stop sharing.
Stop
screen.
sharing.
There may be
Okay.
questions there.
Oh, okay. What are your thoughts on daily aspirin? Yes, daily aspirin, you can again fine-tune your risk assessment by doing a calcium score. Now, the guidelines have gone back and forth about this, right? So the Europeans actually do recommend aspirin for anybody with diabetes and moderate risk and higher. One of the ways to define that risk is do a calcium score. If the calcium score is more than 100, those people will benefit from daily aspirin. Is there a correlation between type 2 diabetes and hypertension? Correct. As people have more than 10 years of diabetes, their risk of hypertension increases because of increased arterial stiffness and renal dysfunction as opposed to a control population. So more so for the older diabetics than the younger diabetics. I think that's all the questions. I see somebody mentioned exercise with 3 exclamation points. I love that. Yep, primordial prevention, right? Not just all about drugs. Yeah.
You had mentioned what is the
So the loop diuretics are the ones that mostly cause it. Most of our heart failure patients are not being treated just with thiazide. In fact, if you look at the, this is data from the blood pressure literature, hydrochlorothiazide is really not a diuretic of any kind. So if you're using chlorthalidone, you will get a few pounds of weight loss, but it's mostly refers to the loop diuretics. About half. So if I have somebody on 40, I'll cut it down to 20. Just anybody, especially when I'm starting it. So, and then I'll get them back within 2 weeks to reassess their volume status and their B1 and creatinine, as well as their hematocrit, and see, if I need to. This is for the vast majority of outpatients. Obviously, you have sicker, advanced heart failure patients. You may not need to cut it down by that much. Say that again?
Guys cluster out there in the statins study, where the HPS4S and all those, she didn't see rosuvastatin and pitava there.
Oh, which one? That was an older slide. Which one? Which statin are you referring to? Pitava?
Yeah, Crestor.
Oh, Crestor. Yeah, that's there from the Jupiter data, and there's clearly analysis of that too. It's an older slide, so I haven't updated it. It's true for all of the statins. Yeah.
One of the things here is trials, the CV outcome trials. A lot of people forget. All of them were trying to improve their blood.
Right.
And when you do another analysis, they have and so the best outcome is so we still so studies don't show clearly that blood sugar not controlling it is
Correct.
not a good idea.
Absolutely.
So that you still have to focus glycemic control as one.
Absolutely, yeah. You cannot disregard that, but this is just sort of a nice side benefit to have. Those are concordant between Europe and the US because those guidelines were written jointly. The inclusion of SGL, ACC, AHA, and ESC. They're all confluent. They all got together for the first time. The lipid guidelines have not done that, but for the heart failure guidelines, they did that. Okay. Found that combining had many added benefits. Yes, combining is a good idea. We do combine it from time to time. The issues become around cost, mostly around cost. But, you know, if you have somebody who has both of those problems, getting admitted again and again for ischemic cardiomyopathy with a preserved ejection fraction, then certainly you can think of patients who might benefit from both.
You see a lot of patients that do it and called VAC. So, what is the role of SGLT2 inhibitors? Have a VAD?
With a VAD? I'm not aware of any. I'm sure.
Because they're diabetic, and the question.
Yeah.
Some of them do have higher creatinine.
Right. I think theoretically, so there's this well-known concept about how VADs lead to myocardial recovery, and eventually you could come off a VAD. And so in those individuals, you clearly want to see myocardial recovery accelerated with the biological properties. But I would imagine all of the trials that I showed you today had VADs as an exclusion. That's a standard exclusion criteria. So I'm not aware of someone who's done a trial specifically in diabetic patients with VADs looking at that, but that would be a great concept to test. Maybe you should work on that. Yeah. Yeah.
Noted that increase in I don't see it in fact. One or two patients. What is GLP?
Okay.
Volume issue. One of them it was Dr. Seiler's the patient. I have to actually worried so much that any autonomic neuropathy. You know, so is there anything that you
I've not noticed it in my practice. I can look it up. The only mechanism I'm aware of is just a natriuresis diuresis that would lead to a reflex tachycardia, but that should.
GLP-1.
Yeah, not as much.
Yeah, the interesting thing is that in the studies early on, these was like not be 4 or 5 weeks,
Right.
you know, but it wasn't. It was like 20 to 30. 25, 20. One more patient.
So interesting.
Yeah.
Yeah. Okay, thank you guys.
Thank you.